Welcome to this explainer, everyone. Let's just jump right in, because today we are stepping into the incredibly fast-paced world of pediatric medicine. We're going to build up your clinical mindset and, well, kind of transform you into a pediatric detective. Your mission? Decoding one of the most common, but let's be honest, nerve-wracking presentations out there. The screaming child with a fever and a rash. So, let's get started.
Picture this. You're the triage physician. A frantic parent rushes in and their kid is just burning up with a fever, skin absolutely covered in a rash. The clock is literally ticking. You have to ask yourself in a split second, is this just a passing viral annoyance, or are we looking at a life-threatening medical emergency? The stakes absolutely couldn't be higher here. Your visual assessment skills, paired with rapid clinical reasoning, are for sure your best tool.
Okay, let's dive into this. Here is our diagnostic roadmap for the explainer. We'll hit red flags and initial triage, build our diagnostic algorithm, check out fever and rash timing, look at maculopapular and vesicular cases, tackle petechial emergencies, and wrap up with Kawasaki disease and some clinical pearls.
Starting off with Section 1, red flags and initial triage. Because before we even get distracted trying to name the specific rash, we have to rule out immediate life threats.
Think of this as your ultimate do-not-miss checklist. If a kid presents with a fever alongside a non-blanching rash, a rash that doesn't fade when you press on it, or if they have altered mental status, signs of shock or poor perfusion, neck stiffness, severe mucosal involvement, or if they happen to be immunocompromised, alarm bells should be ringing loudly. Checking these red flags is your absolute immediate priority. If you see them, you immediately trigger your ABCDEs, initiate sepsis screens, secure IV access, and start empiric antibiotics. You stabilize first and ask questions later.
Moving right along to Section 2, the diagnostic algorithm. Once the patient is stabilized and we have a little breathing room, we need a structured, step-by-step reasoning process.
Let's walk through this quick pediatric framework. Step 1 is the child toxic or stable. Step 2, and this is your most crucial fork in the road, is it blanching or non-blanching? Press a glass against that skin. If it doesn't fade, you're heading straight down an emergency pathway. Step 3, what's the rash morphology? Is it maculopapular, vesicular, petechio? Step 4, check for mucosal findings, like in the mouth or the eyes. And finally, Step 5, figure out the timing of the fever versus the rash.
Which brings us perfectly to Section 3, fever and rash timing. The historical timeline of these symptoms, it's often the ultimate exam gold. Asking the right questions about timing matters so much because, well, disease progressions vary wildly. Take measles. The fever runs high for days before a rash ever even shows up. Compare that to scarlet fever, where the fever and rash strike simultaneously on day 1. Then you've got roseola. This is a classic sequential story. The child runs a high fever, the parents think the kid is cured because the fever finally breaks, and then, boom, the rash erupts. Finally, if you're seeing a persistent fever lasting more than 5 days alongside a rash, Kawasaki disease shoots right to the very top of your list. Let's get into Section 4, maculopapular and vesicular cases. This is the climax of our investigation, the visual evidence. We're starting with the generally more benign, blanching presentations.
Notice the striking differences in how these rashes spread. Look at measles on the far left. A high fever accompanies confluent maculopapules that literally start at the hairline and track relentlessly downward over 3 days. Now compare that to the middle figure, rubella, where the rash is way more discrete and spread out, usually with a milder, lower-grade fever. And over on the right, scarlet fever shows unique features like that paleness around the mouth, and the rash gets super dense in the skin folds, like the armpits and groin, all while the kid remains febrile.
To really lock in these diagnoses, you've got to hunt for the pathognomonic signs at the bedside, those unique clues that practically scream a specific disease. For measles, remember the 3 C's: cough, coryza, and conjunctivitis. Plus, look for those tiny white Koplik spots inside the mouth. On the flip side, scarlet fever pairs its rash with a sore throat, a bright red strawberry tongue, and a rash that literally feels like rough sandpaper when you rub your hand over it.
Now, you might look at these fine pink macules and papules and instantly think, oh, viral exanthem. But actually, this is a morbidly drug eruption. This is exactly why your history taking as a pediatric detective must always include recent medications. A simple antibiotic reaction can perfectly mimic a viral illness.
Sometimes the shape of the rash tells you exactly what happened. Check out this distinct red target-like plaque.
This is erythema migrans, the primary skin lesion of Lyme disease. Seeing this target shape should instantly pivot your questions to outdoor travel, camping, and potential tick exposures. Moving over to vesicular rashes, what we're looking at here is chickenpox. The kid probably has a low-grade fever, but the true diagnostic giveaway is right there on the skin. You can see flat macules, raised papules, and fluid-filled vesicles all coexisting at the exact same time right next to each other. So, the crucial point here is remembering this classic phrase, dewdrop on a rose petal. It's highly testable, surprisingly poetic, and just a perfectly accurate descriptor for varicella vesicles. It beautifully describes that clear, fluid blister sitting delicately on an erythematous, red base. Lock that phrase into your memory for sure. All right, Section 5, petechial emergencies. We're shifting gears completely now. Everything we just looked at blanched. Now we enter the territory of non-blanching rashes, and your heart rate should absolutely be going up, because this signals a true medical emergency.
Take a look at this dark, widespread purpura. If you have an ill, toxic-appearing child whose rash looks like this and refuses to blanch under pressure, you must treat it as meningococcemia. Do not wait. This is a rapid-onset, devastating infection, and your immediate, aggressive intervention is literally the only thing standing between this child and a tragic outcome.
However, it's worth noting that not all purpura means sepsis. Notice how this palpable purpura is heavily concentrated exclusively on the gravity-dependent areas, like the legs and buttocks. That specific distribution is a massive clinical clue for identifying Hennig-Schulman purpura, which is an immune-mediated condition, not a rapidly fatal infection. And finally, Section 6, Kawasaki disease and pearls. We're going to cover a unique, prolonged fever condition, and then wrap the whole shebang up with some rapid-fire takeaways.
This erythema multiforme rash right here on the child's trunk is a classic sign of Kawasaki disease, which is notoriously polymorphous, meaning the rash can take a bunch of different forms. The key trigger in your mind needs to be this. If a child has an unexplained fever lasting longer than 5 days, you must actively search the skin for a rash just like this.
Since there isn't a single magical blood test for Kawasaki disease, you have to play detective and piece these clues together. You want to look for that fever over 5 days, bilateral conjunctivitis, cracked lips or a strawberry tongue, swelling or peeling of the hands and feet, and an enlarged cervical lymph node. Recognizing the specific combo of findings early is absolutely vital. Missing it can lead to severe coronary artery aneurysms. You are quite literally protecting their heart by spotting this.
Okay, time for the rapid-fire summary. Let's lock in these pearls. Number 1, fever plus petit t equals an immediate medical emergency. Number 2, roseola is your sequential classic. High fever first, fever breaks, then the rash. Number 3, measles is all about those 3 C's and Koplik spots before the downward spreading rash. And finally, always check the vaccination history. It's your ultimate cheat code here.
Which brings us to our final, critical thought for you today. You now know that the simple act of pressing a glass to a rash to see if it blanches separates a routine checkup from a race to save a life. But what happens when a rash is still evolving, or when a superbug breaks all these classic rules? Well, that is the true challenge of the pediatric detective and a mystery for our next explainer. Keep asking the right questions, and we'll see you next time.